Most commonly recorded ECG is a 12-lead ECG. 12 leads in a standard ECG are as follows. Standard limb leads 1, 2, 3. Augmented limb leads AVR, AVL, AVF. Chest leads V1, V2, V3, V4, V5, V6. Thus, a standard 12-lead ECG does not include right chest leads known as V3R, V4R, V5R, etc. But in most cases, 12-lead ECG includes a long rhythm strip, either lead 2 or V1 or both, for facilitating rhythm analysis. If the ECG machine has only a single recording channel, 12 leads are recorded sequentially. More sophisticated recorders have facility to record 3 or even 12 channels simultaneously. Simultaneous multi-channel recording can record all leads of a single beat and is better for analysis of complex heart rhythm abnormalities. Electrode combination for limb leads are as follows. Lead 1, left arm positive, right arm negative. Lead 2, right arm negative, left foot positive. Lead 3, left arm negative, left foot positive. Unipolar limb leads are derived using the limb lead electrode potentials. All the 3 limb leads are internally connected to a central terminal, Wilson's central terminal, using fixed value resistors. Usual limb lead recordings are called bipolar recordings, with one limb serving as positive electrode and another as negative electrode, as illustrated above. Unipolar recordings are obtained by taking the limb lead electrode as positive and central terminal as negative. Unipolar limb leads are called VR, VL and VF, depending on whether the positive electrode is at right arm, left arm or left leg. Voltages of these recordings can be augmented by disconnecting the connection to the corresponding limb electrode from the central terminal, causing almost 50% increase in the amplitude of the recordings. The augmented limb leads thus generated are called AVR, AVL and AVF. Augmented limb leads were described by Goldberger in 1942. While monitoring ECG in an intensive care unit, the limb electrodes are placed on the body at a point close to the origin of the limbs. This is to reduce movement artifacts in the tracing. Placing the leads on the body also prevents tethering of the person and allows free movement of the limbs. Same method is followed while recording ECG during an exercise test. Most modern monitors have the option to use chest leads in addition to limb leads. When chest lead monitoring is needed, additional electrodes are placed on the chest. Chest lead monitoring is useful in picking up ST segment changes. ST segment changes occur when there is a decrease in blood supply to heart muscle. This may be associated with chest pain. Location of the leads on the chest depends on the type of patient. While locations on the front of the chest are available in chest pain patients, a surgical patient may require different locations depending on the location of operation and dressings. Leads placed in the foot pipe may be used in some rare situations to decipher difficult heart rhythm abnormalities. These are known as esophageal leads. Mason-Leica modification of 12-lead ECG is most popular during treadmill exercise test. It can also be used in the electrophysiology laboratory along with electrodes within the heart. In this lead system, limb electrodes are placed on the nearest location on the body to prevent artifacts due to limb movement during exercise. Chest electrodes are placed in the conventional positions. Difference in pattern of the modified 12-lead ECG mandates caution while trying to interpret Q waves and other abnormalities on a Mason-like car modification. This system is mainly meant for assessment of ST segment deviations and heart rhythm abnormalities during exercise test. Lewis lead is a modified lead to enhance the amplitude of P waves and thereby enable better arrhythmia analysis. Right arm and left arm leads are repositioned on the chest as shown in the image. This lead system is useful in detecting P waves during a wide QRS tachycardia and helps in differentiating between ventricular and supraventricular tachycardia. Supraventricular tachycardias are abnormal rhythms originating above the ventricles. Atrial repolarization wave or TA wave is usually not evident in the ECG as it has a low amplitude of 100 to 200 microvolts and is usually hidden in the QRS complex. It can also extend into the ST segment, causing ST segment depression, especially during an exercise test, and cause a false positive response. A representative image of the TA wave is shown here. A modified limb lead system for detection of atrial repolarization on surface ECG has been devised by Shivaraman J and colleagues. This lead system has been shown to be useful in detecting atrial repolarization on surface ECG, more so in case of complete heart block, where most of the atrial repolarization activity is not masked by ventricular activity. Now we will see how the cardiac chamber enlargements are inferred from the ECG. Enlargement of the atria are reflected in the P wave, which represents the atrial electrical activity. Normal P wave has a maximum amplitude of 2.5 mm and width of 2.5 mm on the ECG. An increase in the amplitude of P wave is an indication of right atrial enlargement. An increase in width of P wave an indication of left atrial enlargement. When both atria are enlarged, both width and amplitude of the P wave are increased. Diagrammatic representation of left atrial enlargement with wide and notched P wave known as P mitral. Diagrammatic representation of right atrial enlargement with tall peak P waves known as P pulmonale. Ventricular enlargement is indicated in the QRS complex, the activity of the ventricles. There may be secondary changes in ST segment and T waves. ECG changes in left ventricular hypertrophy, the technical name for thickening of left ventricle, is divided into left ventricular volume overload and pressure overload patterns. Similarly, right ventricular hypertrophy is also divided into pressure and volume overload patterns. In the ECG, left ventricular volume overload is indicated by small initial Q wave, tall R wave, and upright tall T waves in V5, V6. Left ventricular volume overload can occur if there is a leak in the aortic or mitral valve or large defect in the wall between the two ventricles. Tall R wave in V5, V6 will be there in left ventricular pressure overload as well. ST segment will show a down-sloping depression and T wave will be inverted. These changes are called strain pattern. This pattern can occur in high blood pressure and in obstruction to the aortic valve. A simple measurement for left ventricular enlargement on ECG is Sokolov-Lyon criteria, which is often printed on automated reports. Sum of S wave in V1 and R wave in V5 or V6 more than 35 mm or R wave in V5 or V6 more than 26 mm is considered as significant as per this criteria. This is based on tall R waves in leads facing the left ventricle and deep S waves in leads facing the right ventricle. Right ventricular volume overload manifests as RSR prime pattern in lead V1, which is also known as incomplete right bundle branch block pattern. It is typically seen when there is a defect in the wall between the two upper chambers of the heart. Right ventricular pressure overload manifests with tall R wave, downsloping ST segment depression, and T wave inversion in V1. The pattern is similar to that of left ventricular strain pattern, but noted in leads facing the right ventricle. It occurs when the pressure in the blood vessels to the lungs are high or when there is obstruction to the pulmonary valve. Mean electrical axis can be calculated for the P wave, QRS complex, or the T wave. It can even be calculated for the segments like ST segment, though it is seldom done. Most often, only the mean QRS axis is calculated, and when electrical axis is mentioned, generally only mean QRS axis is meant. QRS axis can be altered in various disease states like conduction defects within the ventricle, heart attack, enlargement of heart chambers, and change in position of the heart. For calculation of mean axis of the QRS complex, the amplitude of the negative waves is subtracted from that of the positive waves while plotting on the graph using lead 1 as x-axis and AVF as y-axis. The electrical axis of lead 1 is 0 and that of AVF plus 90 degrees. Resultant is taken as the mean QRS vector and the deviation from lead 1 the mean QRS axis measurement. Conduction abnormalities between the sinus node and the atrium are known as sinoatrial conduction abnormalities. Abnormalities in the conduction between the upper and lower chambers is known as atrioventricular conduction abnormalities. Abnormalities of conduction within the ventricles are called intraventricular conduction defects. Similarly, there could be interatrial and intraatrial conduction abnormalities as well. The former is between the two upper chambers, while the latter is within the upper chamber. Sinoatrial conduction abnormalities could be first degree, second degree, or third degree SA blocks. But it is not possible to identify first degree and third degree SA blocks on surface ECG as the sinus node activity is not visible. First degree SA block means a delay in the conduction from the sinus node to the atrium without any loss of signals. In second degree SA block, there is intermittent conduction across the sinoatrial junction. This is manifested by intermittent absence of P waves in the surface ECG. Second degree SA block is the only type which can be diagnosed from the surface ECG. Third degree SA block means that there is total absence of conduction from the sinus node to the atrium. In the surface ECG, this will manifest indirectly as absence of P waves originating from the sinus node. P waves originating from another part of the atrium may be there with a different shape and electrical axis. Total absence of sinus node activity and total absence of sinoatrial conduction cannot be differentiated from surface ECG. Sinus arrest is another condition different from sinoatrial block. In sinus arrest, sinus node fails to produce signals. It could be intermittent or prolonged sinus arrest. Intermittent sinus arrest will appear like skipping of P wave, while prolonged sinus arrest will appear as a prolonged pause. Sometimes a slower pacemaker at the atrioventricular junction or the ventricles may take over signal generation. Sinus arrest is one of the manifestations of a disease known as sick sinus syndrome. Symptomatic sinus pauses are treated by implantation of a permanent pacemaker. Pacemaker is an electronic device usually implanted under the skin and connected to the heart using electrode wires introduced through blood vessels known as leads. Interatrial block has been well recognized in ECG only recently. In partial interatrial block, the P wave is wide and notched, without left atrial enlargement. In advanced interatrial block, the P wave is wide and biphasic in leads 2, 3 and AVF. Inversion of terminal portion of P wave is because of delayed activation of the left atrium from below upwards due to the block in the conduction bundle in the upper part. Upward activation is shown as negative in leads from the lower part of the body 2, 3 and AVF as the activation moves away from those leads. Atrioventricular block is divided into first degree, second degree and third degree or complete heart block. In first degree AV block, there is only prolongation of conduction without any P wave being non-conducted. It manifests in ECG as a prolonged PR interval. In second degree AV block, there are intermittent non-conducted P waves. There are two types of second degree AV blocks. In type 1, there is progressive prolongation of PR interval followed by a non-conducted P wave. In type 2, there is no progressive prolongation of PR interval, but there are intermittent non-conducted P waves. Type 2 is more serious. In complete heart block, also known as complete AV block, none of the P waves are conducted to the ventricles. The ventricles are activated by a subsidiary pacemaker either from the AV node or the ventricles. P waves are seen at a higher rate than the QRS complexes without any relationship between the two. If the subsidiary rhythm is originating from the AV node, the QRS complex will be narrow. When the subsidiary rhythm originates from the ventricle, the QRS is wide and the heart rate lower. Now we will move on to heart rhythm disorders originating from the upper part of the heart known as supraventricular arrhythmias. Supraventricular means above the ventricles. Supraventricular ectopic beats are premature beats originating above the ventricles. Supraventricular ectopics are the commonest form of supraventricular arrhythmia. They can occur in isolation or in sequences of couplets. If more than 3 are seen in a sequence, it will constitute a short run of supraventricular tachycardia. Supraventricular ectopics are common in the setting of atrial dilatation due to chronic obstructive lung disease or reduced pumping function of left ventricle. Supraventricular ectopic beats have a narrow QRS complex preceded by an abnormal P wave. They are also called supraventricular premature complexes as they occur before the next expected sinus beat. In this ECG shown, the abnormal P wave is superimposed on the preceding T wave. QRS complex of SVPC is almost like that of the normal sinus beat. Abnormal beat is followed by a pause. Supraventricular tachycardia is a fast, regular rhythm. Supraventricular tachycardia can be recognized on the ECG as a narrow QRS tachycardia with either absent P waves or P waves which are distinctly different from those in sinus rhythm. There are several types of supraventricular tachycardias based on the mechanism. Commonest form in adults is called AV nodal reentrant tachycardia or AVNRT. It is due to a circus movement of signals within the AV node. Supraventricular tachycardia is often initiated by a supraventricular ectopic beat which sets off the circus movement. This ECG shows a supraventricular ectopic with a different type of P wave marked by the red line, initiating a run of supraventricular tachycardia. This sequence was captured from the storage memory of the intensive care central monitor. SVT is the short form for supraventricular tachycardia. Preceding sinus rhythm shows regular sequence of P waves followed by QRS complexes. During SVT, P waves are not seen because they are occurring along with the QRS complexes in AVNRT type of supraventricular tachycardia. In this case, the supraventricular tachycardia terminated spontaneously. This was followed by a pause and then a ventricular premature complex, and 2 beats originating from the AV junction marked as J in the tracing. Following beat looks like a ventricular ectopic beat superimposed on a sinus P wave. Last beat in the sequence is a normal sinus beat. Such irregular sequences can occur after termination of a tachycardia. This ECG shows a regular junctional rhythm originating from the AV junction. Tall peak T waves marked by pink arrows is another associated abnormality not due to the junctional rhythm. Tall peak T waves can occur when the blood level of potassium is high. No P waves are visible in this junctional rhythm as atrial activation coincides with ventricular activation. This is because signals pass simultaneously upwards and downwards in this junctional rhythm. Junctional rhythm occurs as a subsidiary rhythm when the sinus node is suppressed due to some reason or when there is complete sinoatrial block. This ECG shows another variety of junctional rhythm in which P prime waves are seen after the QRS complexes. This is because the rhythm originates from the lower part of the AV junction. It takes more time to reach the atria than the ventricles. So, a retrograde P prime wave is seen after the ventricular activation, which is the QRS complex. Timing of the T waves, which is different from that of the retrograde P prime waves, have been marked in lead V2. In this ECG, P waves marked by blue arrows are inverted in leads 2, 3 and AVF. These leads are directed towards the lower part of the body. Hence, inverted P waves in these leads mean that the atrial activation is proceeding from below upwards. Retrograde activation from below upwards indicates that activity originates from the lower part of atrium known as low atrial rhythm. This rhythm also occurs when the sinus node is not functioning well as a subsidiary rhythm. This ECG shows multiple shapes of P waves marked M seen in short runs of tachycardia. This is characteristic of multifocal atrial tachycardia. Sinus P waves marked S are seen after the pauses. Multifocal atrial tachycardia is sometimes called as chaotic atrial rhythm because of the variability in atrial activity. Multifocal atrial tachycardia can occur in those with chronic obstructive lung disease. Atrial fibrillation seen in this ECG is the most common sustained arrhythmia originating from the upper chambers of the heart. AF can be recognized in the ECG with absence of organized atrial activity and presence of fibrillary waves. AF can be either fine AF or coarse AF depending on the amplitude of the fibrillary waves. In this ECG, it is fine atrial fibrillation because the fibrillary waves are hardly seen in most leads. In atrial fibrillation, the atrial rate is very high of the order of 450 to 600 per minute. But most of the signals are blocked in the AV node so that the ventricular rate does not go that high. Still, it may be around 120 per minute in most cases. It can be slowed down using medications. In this ECG, the ventricular rate is controlled. Atrial flutter is a regular rhythm originating from the upper chambers of the heart. Atrial rate may be 250 to 350 per minute or even more. Difference from atrial fibrillation is that organized atrial activity is present. But all the signals are not usually conducted down to the ventricles in atrial flutter. In the ECG illustrated, only alternate flutter waves are conducted down. Hence, the ventricular rate will be only half that of the atrial rate. If all the flutter waves are conducted down, as occurs rarely, the ventricular rate will be dangerously high. Next comes ventricular arrhythmias. Ventricular ectopic beats, also known as ventricular premature beats or complexes, VPB or VPC, sometimes PVC, premature ventricular complexes. Ventricular premature beats are easily recognized on the ECG by their wide bizarre QRS complexes, not preceded by a P wave. Secondary ST depression and T wave inversion when the QRS is dominantly positive are also seen. Ventricular ectopic beats are followed by a compensatory pause before the next sinus beat. Coupling interval is the interval between the VPC and the preceding sinus beat. Initial two VPCs in this ECG are isolated, while the last two occur in rapid sequence as a couplet. VPC couplets may be a forerunner of ventricular tachycardia. Isolated VPCs and the couplet are followed by a compensatory pause. All the VPCs have same shape or morphology, monomorphic, indicating the same focus of origin, unifocal. Unifocal VPCs usually have the same coupling interval. ECG showing ventricular ectopic bigeminy with group beating of 2 beats followed by a pause. Each narrow QRS sinus beat is followed by a wide QRS ventricular ectopic beat. Narrow QRS sinus beat has a preceding P wave, while the wide QRS ventricular ectopic beat does not have a preceding P wave. Monitor screenshot showing ventricular premature complexes occurring in a trigeminal sequence, another form of group beating. 2 sinus beats followed by a ventricular ectopic beat, ventricular trigeminy or VPC trigeminy. ECG showing VPC salvo. The original meaning of the word salvo is a series of shots fired in rapid sequence from a gun or simultaneously from multiple guns. Here it is a salvo of 3 consecutive ventricular ectopic beats. It can also be considered as a short run of non-sustained ventricular tachycardia. Isolated VPC is seen subsequently. This ECG shows multiple short runs of ventricular tachycardia. Ventricular tachycardia is a fast rhythm originating from the lower chambers of the heart. If it lasts less than 30 seconds, it is called non-sustained ventricular tachycardia, NSVT. Ventricular tachycardia is much more dangerous arrhythmia than supraventricular tachycardia. Here it is a sustained ventricular tachycardia which typically lasts more than 30 seconds. Sustained ventricular tachycardia is a medical emergency. If it is not responding to medications, a controlled direct current shock is given using a defibrillator to abolish this rhythm. After that, usually sinus rhythm is restored spontaneously. This is a monomorphic ventricular tachycardia, meaning that all beats have the same shape in a given ECG lead. This is another arrhythmia originating from the ventricles known as accelerated idioventricular rhythm. Rate is slower than 100 beats per minute and does not qualify for the designation of tachycardia. AIVR is a classical arrhythmia seen after a blocked blood vessel to the heart muscle is opened up either by clot dissolving medication or by mechanical removal in angioplasty. AIVR usually needs no specific medical treatment as it subsides soon. QRS is wide as in other rhythms originating from the ventricles. Ventricular fibrillation or VF is a life-threatening arrhythmia which leads to death unless promptly corrected by electrical defibrillation, direct current or DC shock. In VF, the electrical activity is so disorganized that no ventricular contraction is possible and ventricle remains still in a state of cardiac arrest. Ventricular fibrillation is recognized on the ECG as a highly disorganized electrical activity. Each wave has a different shape. When multiple simultaneous leads are available, as in this case, the shape is different between the leads as well. If defibrillation is not immediately available, chest compressions and artificial breaths have to be started immediately, that is, cardiopulmonary resuscitation or CPR.